right, so welcome from Symptoms to Solutions, our learning community session 2 for behavioral health psychopharmacology for refugees and migrants. So we'll go ahead and get started. I'd like to introduce myself. My name is Sonia Rollins. I am the Learning and Development Coordinator here at RMTAC, the Refugee and Migrant Technical Assistance Center for Behavioral Health. And I'm so happy to be here with you today. This session 2 is focusing on solutions for psychopharmacology integration. If you didn't attend session 1, don't worry. We provided a written summary to your emails, and also I'll give a quick recap in just a moment. So if you didn't attend session 1, not to worry. Whether you were here for both sessions or one, we hope this learning community environment can be a place where we can foster collaboration, share insights, knowledge, resources, best practices, and that's the power of this type of learning environment. It's what differentiates a webinar from a learning community. Learning communities are active engagement and collaboration, and that's actually part of the vision that SAMHSA, our funder, had for RMTAC specifically to create learning opportunities such as this, where providers such as yourselves can learn to apply the knowledge that you gain from all the amazing avenues and places that provide information. So that's a little bit about how learning communities and why they're maybe a little bit different than a webinar. So ultimately, we're happy to have you here and encourage you to participate, ask questions, interact with each other, and support each other throughout the session. Let's get into the agenda. We have a robust agenda planned for today. So we'll begin with introductions, an icebreaker. We'll talk about the learning outcomes that we hope to accomplish by the end of today and the learning community as a whole. We'll hear from subject matter experts on navigating barriers to motivational interviewing. We will have a collaborative breakout session. I'll detail more about what that's going to look like later on. We'll hear from our last subject matter expert on how to navigate solutions for barriers such as medical education. All right, so I'm excited to introduce our subject matter experts. They accompanied us in session 1, and they're also here in session 2. We have Dr. Hector Colon Rivera with us today, a quadruple board certified psychiatrist and medical director of APM, and Candace Rudetsky. Correct me if I say your last name wrong, Candace, but I believe that I said it right. She is our psychiatric nurse practitioner here at RMTAC. We're grateful for their presence and their expertise here today. We also have our facilitators, subject matter experts. You'll meet with them in your breakout rooms. They are clinical consultants here at RMTAC. So thank you, Dr. Mutsa. Thank you, Dr. Mohammed Ali, for sharing your experiences and being here with us today. They have extensive knowledge and experience as well. We have our RMTAC team. They do a lot in the background, make sure things run smoothly. So if you ever have a technical question while you're here in the Zoom, feel free to reach out to any one of them. They'll have producer in their name in the chat, so they're here to help. Okay, let's get into the topic for today then. And I wanted to give a quick refresher, especially for those who didn't attend session 1. And even those who did, it was a few weeks ago. I wanted to get into the why. Why this topic? Why psychopharmacology for refugees and migrants? There's several reasons why we chose this topic along with our RMTAC clinical experts. One of the reasons is the CTA request. So CTA requests is the request that you as providers can submit to RMTAC, and you'll be able to hear back from our experts and be able to guide you and help you out through a variety of topics. One of the requests that we received, or a few of them, had to do with needing guidance in navigating psychopharmacological interventions for diverse refugee and migrant communities. Many of those providers were looking for strategies to overcome barriers. So that's one reason. Also, our RMTAC clinical experts conducted an extensive literature review of over 3,000 articles. That was a big job they all did. 143 of them emphasized the unique mental health challenges faced by marginalized groups and the importance of appropriate medical management to address their specific needs. So it's a big thing that they found throughout the 3,000 articles that they did. Lastly, we did a needs assessment. RMTAC, when we opened our doors, we conducted needs assessment across a variety of organizations. You may have received that email to let us know what are your needs in this current time. And many providers indicated a high interest in training and assistance with destigmatizing behavioral health care and psychopharmacological interventions among refugees and migrants. So it's a topic that is highly requested, and we hope you find value in it as we continue to discuss psychopharmacology and all the resources that we can provide, you all can provide to refugees and migrants. A quick review of session 1. This learning community, as it says in the title, is from symptoms to solutions. So last session, we focused on the symptoms. We explored the prevalence of mental health disorders among refugees and migrants and the current trends. What are the trends we're seeing, which disorders? We discussed the importance of training all levels of staff from the beginning to the end in recognizing signs and symptoms of these mental health disorders. In our small groups, we analyzed how culture might influence those symptomologies. For example, in some cultures, dreaming of your late ancestor might not be a symptom of a mental health disorder, where other cultures it might. So we kind of discussed culture in terms of symptomology. We also examined this community, what barriers this community has to receiving healthcare, such as cultural stigma, lack of trust in the US healthcare system or providers, lack of medical education, language interpretation, and more. So that's kind of a brief synopsis of what we covered in the first session. Now, in this session, for today, session 2, we'll focus on the solutions portion of those barriers. We all want the solutions, specifically about cultural stigma, trust, and general resistance to change. Those of us who have worked in this field for a long time, for many years, you have likely had an experience at some point in your career working with a client where you know exactly what they need, you know what can help them, but for a variety of reasons, they deny that care, or they're just very resistant to it, and they're not open to the idea of the exact thing that can help them. It can be very frustrating as a provider and really draining. In today's session, we'll learn how to apply a few effective strategies, such as motivational interviewing, to support those unique hesitations or resistances that refugees and migrants specifically might have. We'll also enhance our competency on navigating medical education for this population. So excited to dive in, lots of good things ahead. Handing the time over to Dr. Colon. As mentioned, he's a quadruple board certified psychiatrist. A little bio on him before I hand over the time to him. He is a medical director of APM, a nonprofit organization dedicated to enhancing the quality of life for Hispanic communities in the Philadelphia region through a variety of services, behavioral health, substance abuse disorders, foster care, education, much more. Dr. Colon is also the co-founder and chief medical officer of OK Health AI, an attending physician at Western Psychiatric Institute and Clinic and UPMC, a clinical advisor of the Advisory on Alcohol and Other Drugs Committee for Pennsylvania. He's also an active member of the Hispanic Caucus for American Psychiatric Association. So an extensive bio. Thank you, Dr. Colon. We welcome you and are excited to hear from you.
Yes, thank you. Thank you. And today we're going to talk about motivational interviewing as another tool, right, that we can use when talking to a patient, especially those patients that are in contemplation, pre-contemplation, or denial stages of change. And we're going to talk a little bit more about the stages of change. Okay, some of our objectives, so 3 objectives. So we're going to learn how to apply motivational interview, and we're going to apply it in small groups later on today. We're going to incorporate the spirit of motivational interviewing, which are the collaboration, acceptance, education, and compassion. Nowadays, we use empowerment as well as one of the spirits of motivational interviewing. We're going to talk about the questions, reflective listening, and summarize how we use this strategies to facilitate meaningful behavioral changes. Okay, so what is motivational interviewing? And motivational interviewing come in different definitions, right? But there's one definition that was defined by the creators of motivational interviewing, which is motivational interviewing is a particular way of talking with people about change and growth to strengthen their own motivation and commitment. And there's two words there, like it's change and growth, which are the main they're active, tense, and is they're proactive in terms of it depends on the client and no such on the therapist or the counselor. So it's a lot of work on the patient. And in terms of the counselor part, the therapist part is to engage the patient on that meaningful conversation. Also, we need to spot readiness, and that's why it's so important to talk about the stages of change and understanding the commitment the patient has. So motivational interviewing is the benchmark of it are doing more open-ended questions than closed-ended questions, and we talk about more what open-ended question versus a closed-ended question is. We should try to have a ratio between 2 reflections per every question, so less questions and more reflections. That helps to let the patient know that we're listening, we are there, we're present, and we need to avoid more than 2 questions in a row as much as we can. And participants should talk more than us, so that means like 60 to 80% of the time is more them than us talking. And of course, us should talk about 20 to 40%. So 2 words per every 8 words that they say. Yeah, so how come motivational interviewing improves services for refugees and migrants? And of course, we need to understand that motivational interviewing is not a treatment, it's a tool, right, that we use to get that patient or that client to the change they want to see in their lives. So why it matters for refugees and migrants? So we know that refugees and migrants have a lot of, the most common symptoms they bring are depression, anxiety, and of course, symptoms that come with the post-traumatic stress disorders. So there's a lot of past trauma, there's a lot of replacement, and cultural transitions often needed when they come from different places, different locations, and also depending on the culture, right? There is a sense of autonomy. Foster depends where you're coming from, right? Western versus Eastern, but there is a sense of autonomy that they want to have. They want to change because they want to change, not because people around them want them to change. So what is that autonomy in a cultural context? So we need to recognize family and community roles in decision-making process. So a lot of families have different cultures. Like today, I saw a patient that she believed in spirits, right? And to change, the spirits have to be on the same page as her. So how you deal with that, I guess, motivation or support that are spirits that maybe I do not believe in that, but I respect her cultural belief. And so how do I work and include that on a treatment plan for her? Some cultural value collective decision making. So Hispanics, Indians, I see a lot of Arabics, they do respect what the family has to say, right? So in terms of like my kids, my grandma, my grandpa, so it's including them in the treatment plan is really important. So how do I adapt that in my strategies to help that patient? We should use cultural relevant examples and languages to reflect the understanding and respect of their background. And we do that in terms of reflections. Remember, more reflection than questions. So reflecting using the same words or using the same kind of, it's like quoting the patient with different tone that doesn't sound like a question. That's really important. Use their same language so they understand and they know that we're listening. So highlight self-efficacy, which is similar to autonomy. We emphasize the client's strengths and abilities to cope and adapt. We all that have, we need to find them and encourage the client to build confidence in their decision making. I mean, the point of motivational interview is that they can change on their own, right? We not need to push them that hard. So key principles of MI, probably you guys are aware of this. So there's some key principles, which is empathy, self-efficacy, discrepancy. So that we need one, that create discrepancy and ambivalence on the patient, and the role with persistence. We're going to talk more about the role of persistence because I think that's what we crash sometimes. Okay, so these are the ORs. It's like a mnemonic. It stands for open-ended questions, affirmation, reflective listening, and summarizing. And this is the basic strategies for MI. So stages of change. So pre-contemplation. So it's a possible lack of awareness. For example, I mean, my name is Hector, so I'm using opiates for a lot of years. So I do not believe I have an issue, right? Even though I'm using every year. So my belief is that I can stop at any time, but I just don't want to do plans yet. So that's a pre-contemplation. I mean, there's a problem there. I might be like, man, thinking about it sometimes. I'm here because my wife said I'm here. I need to come here, but there's no really acceptance yet or real planning or interest in actually doing something about it. Contemplation, there is already acknowledgement of a problem and there's a need to change. So it's the idea of, I mean, I acknowledge that I'm drinking is affecting my relationship and work. And I mean, I'm here because I want to change, but I'm not ready yet. I'm not there yet. So there's more acceptance. There is acknowledgement of the problem, and I need to change because it's causing problems already. Preparation, gathering information, seeking support for community resources. So that's more into close to I'm setting a date to quit, for example. That will be a preparation, or maybe we should meet more often. So I'm thinking already about what the action plan will look like. Action is actively engaging in new behavior and treatment. Yes, I'm accepting from using opioids. I'm accepting medications for that. So I'm looking for maintenance of methadone, maintenance of buprenorphine, or something like that. Maintenance, I already started taking the medication. I'm already taking therapy. So it's sustaining the change while adapting to the cultural environmental stressors. So I'm in the treatment already. I just need to keep going. Um, Relapse, something people do not make it part of the stage of changes. For me, I think it's a part of changes. And of course, I mean, it's recognizing that is part of or my disease. And I need I can fall, but I can go back in the path. These have number, but they don't have to open. I mean, they don't have to be like one after the next one. I mean, we can be on any stage at any time. Okay. And of course, sometimes people have different, they are in different stages at different point of their life and different stages at different problems. So you can be on action for alcohol, but marijuana, which is a pretty common one, they are in denial. I mean, there's no way marijuana is a drug. So things like that, we need to work on that and probably pick some of the priorities for the patient. Key principle of MI, role with resistance, I think is the main one that we want to target today. So let's see. So how do we resist at different stages of change? So this is really important, right? Because I mean, I think in the last learning, community learning we had, we had some issues spotting the readiness of the patient, and I think that we will struggle with. And without spotting that, it's really hard for us to balance how ready the patient is. So they're reluctant to start treatment. They're reluctant to start medications. Maybe they're open to something else. So it's really important for us to have options for that patient depending on the stages they are, and be prepared to talk about those options depending on the stages of change. A great example is, I mean, when people are in pre-contemplation, there's a possible lack of awareness and what is there for them. So even using motivation interviewing to have that patient coming back to you, even though they are in pre-contemplation. So that's something that we can do. Contemplation probably need to change, but they're not sure about solutions. So giving them a menu of solutions, making them read about them, making them more comfortable, creating the trust, it will help in that stage of change. Preparation, gathering information, seeking support. I mean, we know that they're probably already looking and they're coming back. Action is already, we're already talking about treatment and maybe starting something. Maybe you're not ready to start medications. We can give you a few weeks. You try it for a week and let me know. We can meet more often, but be there for the patient. And already we talk about maintenance and how we can deal with that. Rolling with the system is addressing resistance to psychopharmacology. And we have our expert here, our nurse. And there is a possible reason for resistance. I mean, there are multiple, there are more than four, but fear of change. I mean, that's a big one. Cultural belief. So preference for traditional healing, herbal remedies, uh, for example, I see a lot of people from the Caribbean, and they don't have the remedies here in the U.S. So they need to, I mean, depending what they find in the market, they can treat themselves, but sometimes they don't find it, so they come to the doctor, which is not normal for them. So how you explain that? How you explain that this medication might help them as a herbal is helping if they move back to the country, or was helping when they move back to the country. So we need to talk about that. There's a lot of misinformation. People are getting ideas from like social media. So how we work with that resistance. Stigma around mental health issues is certain in certain communities, especially communities that don't believe in mental health or drug and alcohol is not existent. So recognize the resistance is the first step. We need to notice the behavior. The client might interrupt you. The client might ignore you. It happens a lot with adolescents. Usually have more problems with also male figures than females. Females usually come before the problem is too high. Males are like usually here because someone else brought them, or they were maybe referral from the ER, so something already drastic happened, or they have legal issues. So rolling with that resistance is really important, and it changed by gender, it changed by age. And I'm a male, so I can talk about males. But that's what I see in the patients, right? Especially Hispanics and other, there's a lot of machismos, and probably other cultures have the same. Asians, for example, is a lot of that too, the paternalistic way of looking at society. So preventing resistance. So how we prevent it? I mean, there's a lot of collaboration, MMI, compassion, acceptance, and empowerment. The patient needs to feel that you are there with them. So that's empathy, right? In terms to identify the change talk, there is a mnemonic for that, is the desire of the patient, the ability of the patient. Not all patients have it in the same, even though there's in the same stage of change, the ability to change is not the same, right? And that could be because of society, financial, it could be because, I don't know, even transportation. So all the social determinant of health can cause a difference in the ability to change. Reason, you need to find a reason. The patient has to find a reason. You need to help the patient to find a reason. Even if it's not a personal reason and someone else reason, like my mom, my father, society, my boss. There is always a reason. Legal issues is fantastic. I have patients that have stopped and they're ready when they are in probation. And if they're not on probation, they don't feel ready to change. So even things like that, we need to find it. The only way of finding it is open-ended questions, so the patient tells you and you gather that information. Need to change, and of course, the commitment is needed. They need to come back, right? So we want that. So preventive resistance, so desire that I want to trust the doctor, but I'm not sure if I can. So that's a big one, especially communities and cultures that don't have that figure in their society, societal uh, roles. So the ability, I could try to attend therapy sessions, but I doubt I will feel comfortable. That's a pretty common one. It requires a lot of trust. They trust you with some topics, but not others, especially when they feel that they're vulnerable telling you about that. If I learn the language, I might find a better job, but I'm not sure it's worth the effort. So the reason they want to work. So that's a good reason to do something and help them to do that. The need, I mean, it's important. So when they say that, it's important for me. There is a need there. to change. So this is an example. It's important for me to improve my health, but I'm afraid of the trying. And the commitment, maybe that creates a little bit of ambivalence, but at the same time, they're saying that I can start. So again, MI is all about the listening, right? Identifying those keywords in what the patient is saying. No agenda, right? Opening the question, you just listen to the patient and creating an agenda while the patient is talking. So how to roll with resistance and my options here. So focus on the high quality of hours. So avoid the yes or no responses when opening the questions. So it's important to say, I mean, you can ask what concerns you. I mean, that's a pretty open-ended question, and just add information after that. What brought you here? Yes, it's another open-ended questions. Avoid question that is just a yes or no question. Are you drinking? I mean, that's a pretty straightforward. Yeah, I mean, the question, you can say no, yes, but it's a pre-ended question. Now you need to ask a second question. And remember what I say, you don't want to ask two questions, right? So just give it that open-ended question and let them talk, okay? Affirmation, they're positive reinforcement. And positive and negative reinforcement, that's like a different talk. Sometimes we believe we're doing a positive reinforcement when it comes like a negative way. So we'll be careful with that. But it must be authentic. It promote confidence and self-efficacy. And of course, reflective listening has to be there. More reflections than questions. Remember that. So different ways of rolling with resistance is the reframing, highlight how, for example, how medication can be one component of broader holistic plan. So it's not, medications are not the only way. And you say that, I mean, I can get that. At times when you reframe, you can ask the patient, do you want to know my opinion? Which is like getting outside the role of being a doctor or being a counselor or being a therapist. You're a human being. So do you want to know my personal opinion? And usually I would say 99% of the patient will say yes, so you are kind of getting out of the role and giving them more trust. I'm now acting like, just someone else, a human being. And they usually say yes. So that's you're open, to force or to get more on that reframing, right? That component of the broader. Empowerment is really important. I mean, emphasizing client choices, information exchange. You want to offer actual information in a cultural appropriate manner. So you need to avoid that hat that you are a doctor, right? And be open to just be a human being with that patient. We need to support self-efficacy and recognize emotional reasoning. Avoid the writing reflects. Remember that MI, the practitioner does not try to make things right or doesn't try to change the client behavior. Remember, you're listening, you're looking for keywords, you're using those keywords. That's why we're talking about reflection and not question. We're not doing an intake, we're not following structure. It's a motivational interview. It's an interview, right? But you are not asking a question, two reflections per question that you ask. We have to acknowledge that the right thing of reflex is present and ask ourselves to override it if you catch yourself doing it. We have to step aside and focus on the person in front of us. And it's not about us, it's about the changes that the patient can do. Remember, collaboration and empathy. We're all human beings, and we have to center is patient-centered treatment. Always think about cultural competency. So integrate cultural awareness and respect into the MI. That promote engagement and reduce resistance. Client autonomy and self-efficacy. That's what we want to have. We want the patient to be self-efficacy so they can go home without us and think about their change. And ongoing learning, this is an ongoing process for both, right? The counselor or the interviewer and the patient. And we need to continue to adapt to refine our approaches. And again, people can move around the stages of change. They're not in order. And depending on of the topic, they can change. Like asking someone for capacity is the same as the change. Thank you.
Perfect. Thank you, Dr. Cologne, for all that amazing information. We'll have, some of you will have more opportunity to talk to Dr. Cologne in your breakout rooms and also with our other RMTAC experts. So we're going to dive right into the next portion, which is our breakout sessions. The purpose of this small group activity is to practice applying everything that Dr. Cologne just mentioned. Practice what we preach, essentially, in regard to MI. Rolling with resistance in the moment, whether you're with a client or a coworker. I know when we were talking to Dr. Cologne about this topic, he mentioned how this is something that you can use with your family, even with whoever you're talking to try and listen better and have a better approach. So it's easier said than done sometimes when you're in the moment. So you'll have an opportunity to work together and share experiences and scenarios of what works for you when you are in a situation where you're needing to roll with resistance when you're in these types of situations. So we will have each group will have a SME and facilitator. They'll guide the group discussion. You'll have a producer in there to help take notes. And we ask you to keep your cameras on, especially during this breakout session, so you can collaborate and talk with each other. And remember to pick a spokesperson. As a spokesperson, you'll just highlight your favorite parts or what you took away from the group discussion. So thank you for your participation in those breakout room sessions. I was a little fly on the wall. They were sounding really good discussions. Motivational interviewing is such an extensive topic, right? Today, Dr. Cologne just focused on rolling with resistance, but it's a skill, it takes practice. Something to keep in mind is that if you ever have a case study or a client you're working with and you want to bounce off some ideas, you're not sure what to do, how to approach, that's one of the reasons why RMTAC, why we're here, why SAMHSA funded this type of organization, to be a support to you all. Because it can be hard at times, not sure to know what to do or ideas on how to approach situations. So those breakout rooms are kind of like a mini version of the support that our experts can provide to you on a variety of cases and topics. Before moving on, we'd like to hear from you all. So I'll reach out to group one. Group one, I believe, was, let me look at the breakout rooms. Group one was with Dr. Cologne Rivera. Do we have a spokesperson? Just share your main highlights. What was something that you took away or that you found useful or insightful about your breakout room discussion?
So during our breakout room, we had some examples of assessing readiness and also providing affirmations when a client has low confidence that they can change. And then something I've noticed was you really have to be listening to what the client is telling you, and you have to give an authentic affirmation. You can't just kind of, if they're saying they're sad, you can't say, well, you're not always sad. That's a good thing, right? They're telling you you're sad. So being present would be, I see that you're sad, kind of give that reflection and using open-ended questions to explore that further, and then being authentic as well.
Thank you so much, Gloria. Let's go to group two. What were your highlights? This will be with Dr. Mohammed and our psychiatric nurse, Candice. Any highlights?
Yes. So my name is Libna. I'm a chosen speaker. We discussed identifying that it's important to validate our clients and what they're feeling. Also, start with setting simple goals rather than giving them very extensive list of goals. One of the main components is how you talk to them and speak to them. A lot of reflective listening, treating them with respect and kindness. And because we do want to help them also, and we want to help them make that behavior change, to present some evidence-based information, to even present to them some case studies, if you have, of success stories with clients who were from their background, who did go through and take some steps and the outcome was positive in their favor. I think that's what I wrote. I'm not sure if there's anyone who feels I missed something from my group.
Amazing. Thank you, Luna. So handing over the time to Candace, she is a board-certified psychiatric mental health nurse practitioner with over 7 years of clinical experience. Candace specializes in providing comprehensive medical biopsychosocial assessments to guide patients through their care journey. Candace develops individualized treatment recommendations that may include protocols such as dual sympathetic reset, ketamine infusions, transcranial magnetic stimulation, TMS therapy, integration therapy, medication management, and much more. Candace is one of our psychopharmacologists here at RMTAC and a valuable resource to all of us. So welcome, Candace.
Hi, thank you so much. I'm glad we're all here together today. So some strategies to increase medical education among refugees and migrants. I know in one of our case studies that we did in the breakout room, some of it was medication hesitation, which I think we come across, especially when we look at populations that we work with. There's a lot of stigma about mental health, I think across the United States as well as the world. And of course, culturally that changes per population. So one of the biggest things is just community-based education here at RMTAC. That's what we do. We are here to help educate. So of course, partnering with local cultural organizations, religious group, and community leaders to help provide trusted education. And I think the key word there is trusted, right? Building that rapport and really helping to understand that the information given can be trusted. Of course, peer educators and navigators, so those within the community who can help advocate for their experiences is really important. So training individuals from refugee and migrant communities to serve as health educators is really important. Those who have gone through the experience of trialing medications is really important, and the success stories that come with that to once again build that trusted education. Mobile health clinics and digital resources. I worked in Arizona for a while, and this is actually pretty common, is the mobile health clinic and digital resources. So basically reaching areas that maybe are a little harder to target with those types of clinics. And then we have so many new modalities in terms of WhatsApp, which can go international, to translated educational videos and different modalities to kind of really target areas that are much more rural. And then of course, trauma-informed approaches. So recognizing that our clientele that we work with have all probably gone through some sort of traumatic event, whether while coming to the United States, before, both, and of course, generationally speaking. So really important to recognize complex trauma, post-traumatic stress, and framing education in a way that acknowledge that is key and help to empower our clientele that these symptoms are not odd, it's not strange, and that we're here to kind of validate what they have been through and what they're experiencing and offer modalities to help, which can include medication. And of course, most importantly, culturally adaptive psychoeducation. So each culture that we come in contact with definitely has different thought processes and feelings surrounding mental health. So just being culturally sensitive to that. And I think the key here is to ask questions surrounding their comfort level, what they mean by their symptoms, because everyone, we touched upon this in our last session, is everyone interprets their symptoms differently. So really asking those open-ended questions so they feel comfortable about what's going on. So common medications for the behavioral health concerns. This is just for general knowledge. This is very, very, very superficial. But for depression and anxiety, some of the first couple of medications we try are just usually general SSRIs, which include Prozac and sertraline. There are many, many others, but these are probably some of the most common ones we see, especially fluoxetine or Prozac in children and adolescents. That would be some of the more common ones. And then SNRIs, venlafaxine, duloxetine, bupropion are some other ones that we'll see in the mix as well. For post-traumatic stress, there really is there really is no specific medication, but supportive medications for what they're experiencing. Really, it's the therapeutic side for trauma that is the treatment of choice. But things like SSRIs, the help with the anxieties that come with it, prazosin, which is for nightmares, and sometimes mood stabilizers, depending if people feel like their moods do go up and down with some reactivity, can be beneficial. So those are some things for post-traumatic stress. Psychosis and bipolar. Psychosis is something that's really important that we weed out. What does psychosis look like to us in our American brain, so to speak? We think about hearing things, seeing things as psychosis, and that's kind of a blanket term. Where we have to remember, spiritually speaking, people can feel spirits, they can talk with ancestors, they can have these other experiences, and we really need to check reality testing on, is this something spiritual and cultural, or are we leaning into the realm of psychosis? And that would be treated with second generation antipsychotics, would be our treatment of choice, as some of the ones are listed below. And then bipolar, big mood swings. People are going to be reactive. People are going to have some periods of lowness as they adapt, and also some more maybe motivating, which can be a trauma response. But also we need to see if someone really is having periods of inability to sleep at all, overly excited, you know, maybe having some impulsivity and acting out in ways they wouldn't normally. Those would be signs of bipolar that we definitely need to address before maybe they hurt themselves or others accidentally. And probably one of the most common things outside of post-traumatic stress or diagnoses we'll see is substance use disorder. Last session, one of the attendees spoke about how alcoholism was on the rise across all cultures they saw. So this is where we can help identify early, of course, symptoms. So substances aren't the treatment of choice for them, but also help support substance use disorder with medications like buprenorphine for opioid use, naltrexone, and Comprel for alcohol use, and then bupropion for nicotine use. All those help with cravings to kind of steer away from wanting or needing the medication, which is very, very common.
Great. We have Gloria that has her hand up. Do you have a comment question?
I just wanted to know, is there a reason that trazodone isn't on the list for something as common to treat nightmares? Or why is prazosin preferred over that?
Trazodone is for sleep. Trazodone is for sleep. Honestly, I see more people get more nightmares off trazodone, but it actually can happen. Prazosin, nightmares and flashbacks for sure. And this is just very general, very, very general. This is just, there are many, many tools. So trazodone is super common for sleep disturbances. That would be probably a primary medication for those who are having them. But specifically for nightmares, prazosin is a good medication for that.
Thank you.
Yeah, absolutely. The psychodynamics, pharmacokinetics are very, very intense subjects that can go into really deep detail. But some things that we do need to be aware of is, culturally speaking, we metabolize medications differently. And there are some specific cultures where metabolism is maybe they don't metabolize the medication as well. Many East Asians, for example, are poor metabolizers of certain antipsychotics. So you need to be very careful when you dose them maybe slower, see how they react, or choose a completely different medication. And that's easily accessible through really any pharmacological book that you can find, where it has, like, you know, populations or inhibitors and things like that. We touched upon this, like I said earlier, about the cultural beliefs about medication. Herbal traditional, we talked about that in our group, how, you know, some cultures would prefer to go a traditional medicine route, or have had distrust in Western medicine. So it's really important to build that rapport, educate, utilize what we said in previous slides to really understand where they're coming from before we just throw out medications, of course. Also, I worked at Indian Health Services in Arizona, and we did a lot of blend of not only traditional, but Western meds, and worked you know, side by side with their providers. And then, of course, dietary and environmental factors. Food, gut, microbiome, and lifestyle influences drug metabolism. Really, really important is what was their journey to us like, right? Was there malnutrition? Was there, what was their life like prior to? So we do have those other comorbidities that occur. So that's where we as RMTAC and primary care providers work hand in hand, where we have someone working medically. Now we also can support psychiatrically and bring us all together, which is awesome. These are some more personalized medicine and mental health. With our population, it might be a little bit harder due to cost of some services, but there is some genomic testing nowadays where you're able to see what medications work best. Of course, epigenetics and trauma change everything in someone's body. One thing I'll always say is when something worked for a family member, a lot of times it works for them as for someone else who has blood relation. So it's really important. Hey, did anyone ever, get medicated before? If that worked, we can kind of go that route as a first trial. But also remember that epigenetics and trauma really does change the body's chemistry. And I think that a lot of medicine is going this way nowadays. And I think we as a group of people really working with our refugee and migrant population is the holistic and integrative approach. It's just not the mind and the body anymore. It really is the entire person. And when we treat the entire person and are culturally aware, that includes therapeutic services, primary care services, mental health services in the medication realm. All those combined, you really treat the whole person, which causes much better outcomes. Mental health and medical health is kind of just what I just said, but for the longest time it's been separate. The collaborative care model, which this is up and coming, because when we can catch symptoms at the primary care level and help support with mental health services, we're catching it before it becomes extremely disordered, where people are utilizing substances to an extreme. We catch it before, get to work together and get everyone hooked up with the right services at the start. Will be more preventative for those. And then the culturally competent approaches. Number one, language accessibility. We talked about this a lot, making sure we have trained interpreters and translated medication guides. So those who are seeking treatment truly do make sure they have the best understanding of what's going on. That's very important. Trust building. Like I said previously, it's just understanding that cultural stigma and really building that trust. Meds might not happen at appointment one, but as you build it and they understand more about it, if it's really truly needed, we can hopefully help with that. And then community-based healing. A lot of people that I've worked with in the last 2 sessions are in community health already and are part of the a bigger community that's helping this population. And I think it's really, really important that as a community, as they heal, also their generational wounds heal, and then them as a person heals as well. So it's really important. Wonderful. Thanks, y'all.
Thank you, Candace, so much for that valuable information. To both of our subject matter experts. I've gained so much knowledge from your presentations, and I'm sure everyone else has as well. I realize we are at time, so if you need to hop off, feel free. We'll be kind of summarizing what we've learned throughout this whole learning community and announcing our next topic for the next learning community that we're really excited about. And also, if you attended both sessions, we have the raffle. So hang on with us just a few more moments if you're able. If not, we understand, and thank you so much for attending today. To wrap up this learning experience, let's review where we started and where we arrived at today and what we've accomplished, which is a lot. We learned about cultural factors and how they may influence the presentation and interpretation of symptoms. We analyzed barriers to psychopharmacology care, such as resource scarcity, medical and education, trust and familiarity, cultural stigma, and more. We identified solutions to those barriers, such as motivational interviewing, rolling with resistance, strategies for medical education. Lastly, we engaged in a collaborative environment with each other as fellow professionals, helping each other best serve those in our services. A few closing reminders. I will have a survey link, a QR code in just a moment. Your feedback is so valuable, so we can continue to make these learning communities the best experience for you all here. We're created to help you all and serve you all and support you in the amazing work you do. And a quick reminder about our next learning community. We will have it March 26th and April 9th. We will be sending out those invites soon. So if you're part of our newsletter email list, you will get that invite. It will be Building Resilience, Crisis Prevention and Recovery for Refugees and Migrants Amidst Changing Environments. So we hope this will be really relevant to the current landscape we are living in today. As a reminder, we are here to help. Our services are completely SAMHSA funded, no cost to you. If you or your organization need additional assistance with addressing behavioral health concerns, psychopharmacology concerns, our RMTAC team is here to help. Super easy. You go onto our website, click on request consultation or technical assistance, and we'll be able to help you with a variety of topics. If you're not sure if we can help with a certain topic, submit the request and we will either be able to assist you or guide you to the best place, and we respond within 1 to 3 business days. So here's the QR code. We'll have the link as well in the chat. We'll continue on. It's going to go one by one, but we have the references here. We'll be sending out these PowerPoints so you have the references that both Candice and Hector pulled from. To close out, I would like to thank you all for attending this learning community, for participating, for engaging in conversation, our SMEs for your insights, Dr. Z as well for participating today, and our RMTAC team. So you're free to stay and hang on for the raffle. If not, thank you so much for attending and have an amazing rest of your day and